Hey everybody, I just wanted to I know I say I'm going to spend a couple minutes with you guys every time I start a video, but I'm hoping to be true this time. I want to talk about a subject that for a long time I did not understand. Now, I had heard the term shock thrown around and I knew shock was bad. And, I've seen people in shock, that shock and awe, where they're overwhelmed with emotion, that they're, devastated due to a tragedy. But I didn't know what medical shock was, what the medical condition of shock was. I didn't understand it when I was an EMT. I didn't understand it when I was a paramedic. And I didn't really understand it until I had to teach it. Okay. And then I found out that, it became overwhelming at first because it talks about perfusion, it talks about cellular metabolism, and let's just face it, those things are hard, so I quit listening. And I had no desire to learn it, but once I had to teach it, I had to wrap my head around this. I found out it's not that bad, so I want to share what I learned with you, okay? Bear with me, this is going to take just a second, and it's going to be easy. Okay, so first thing we need to know is what is shock? It's not being overcome with grief. It is not fainting, okay? It is inadequate perfusion to the cells. Okay, now that leads us to the next question. What the heck does perfusion mean? Okay, and keep this simple, guys. You can make this as complicated as you want, but it's not going to do you any good to do that. You need to understand this, and it's not hard. Perfusion is getting oxygen to the cells, period. Okay. Now, if we take the big definition, it's getting oxygen and nutrients to the cells and taking the waste products away. Okay. But quite honestly, unless you're a diabetic, I'm not worried about the nutrients. And if we can get oxygen to the cells, then we have blood flow to carry the waste products away. So the main focus is the patient getting oxygen to their cells? If the answer is yes, and it's adequate, then they have good perfusion and they're not in shock. If the answer is no, then we have a patient that's in shock and we have to figure out how to recognize that. Okay, so let's take this one step farther. Would you agree that we have to have adequate blood pressure to move the oxygen from where it jumps into the bloodstream, into the red blood cells at the alveoli? Okay, so we have to get that oxygen there to the cells throughout the body, especially the cells in those vital organs like the brain, the heart, the kidneys, those things. Okay, so if we have to get the oxygen from point A to point B, it makes sense that we would need a mechanism to get it there. And so our transport system is the bloodstream. Okay, we're going to load up the oxygen on the red blood cell and we're going to move it by way of pressure, blood pressure, down to the cells at those small capillaries. Okay, if we don't have a blood pressure, we cannot move oxygen. It's that simple. Okay, now adequate blood pressure we're looking at 90 systolic is usually more than adequate for most people. Some places are even saying 80 is good. Okay, so it doesn't require that we have a normal blood pressure even. It just has to be above, let's shoot for above 90. Okay, so if we can get that adequate blood pressure, then we're going to move cells. And the cells are going to have oxygen with them, hopefully. Okay, so let's look. What is required to have a good blood pressure? And these are good things to know. Okay, so it takes 3 factors to keep our blood pressure adequate. Okay, the first one is a pump. We need a pump to create the pressure. Okay, so if anything happens to our pump and it is not pumping effectively, then we're not going to have a good blood pressure. Make sense? The second one that we need to have is pipes. Okay, so our vessels. Our vessels need to be intact, not leaking, not bleeding, okay? And they need to be the right size. So if we get vasodilation due to, say, a spinal cord injury, then that's going to mess with our blood pressure because the pipes are going to be huge and that's going to decrease our blood pressure. It's like taking a fire hose and having a 2-inch hose and then running it into a 4-inch hose. You're definitely going to lose pressure with that. Okay. Then the third thing, this is the down and dirty. It's what I call the pudding, simply because, it kind of rhymes. Pressure, pump, pipes, and pudding. Pudding is our blood. Okay. So we have to have an adequate amount of pudding, and we have to have the right flavor. So it has to have red blood cells in it. If it doesn't have red blood cells, it can't carry oxygen. Okay. So adequate pump, pipes the right size and intact, and we have to have an adequate amount of blood with red blood cells. Okay. Now, if we get a patient that's dehydrated, that's going to mess with our pudding because we won't have an adequate amount. We'll have the red blood cells there, but we're not going to have the plasma, the fluid, to move that around, which is that makes our blood sort of dehydrated, which means it shrinks up, there's less of it. Okay. So don't make this hard. This is just a way for you guys to troubleshoot. If you have an inadequate blood pressure, where's my problem? And that's important because we know we have to have a blood pressure to have good perfusion. Okay. So if we get oxygen to the cells, so the oxygen and the glucose go in the cell does its thing with a very complicated process called the Krebs cycle and the citric cycle, and that's where it gets really ugly, and that's where I quit listening. So it suffices for you guys to know oxygen and glucose go in. The body has a process that it converts that to energy and heat. Okay, so the energy is called ATP. That's the energy that the cell uses to do its job and to keep itself alive. Now, the waste product from this, just like if your car is running good, it's going to have carbon monoxide coming out of the exhaust. We expect that. Okay, if the cell is running well, we're going to have carbon dioxide emitted. That cell kicks that back out into the bloodstream. The bloodstream carries it back out to the lungs, and we get rid of it. It's a waste product, but we have a fine-tuned system to deal with that. Okay, so this is good perfusion. This is good amounts of oxygen getting to the cells. Okay, it's called aerobic metabolism. Now, here's what happens if we start to lack the oxygen. If for whatever reason we can't get oxygen there, maybe the pump isn't pumping, maybe patient isn't breathing, maybe the patient's in a room with carbon monoxide, maybe the patient's bleeding, maybe the vessels got huge because this patient experienced a spinal cord injury. There's a plethora of reasons. But regardless, that cell, if it has to operate without oxygen, still is going to get the glucose. It's going to have a process. It's not a great process, but it is a process to create a little bit of energy, or ATP. Only this time we only get 2 units instead of 34. And here's the bad thing. The byproduct of this is lactic acid. So the cell is not creating enough energy to take care of itself and do its job. It's doing the best it can, but without oxygen, that isn't good. Okay? And then we have this lactic acid. Now, if you were sitting in my class, I'd make you repeat 3 times. Acid is bad. Okay? Acid is really bad. Can you imagine if you just poured acid into your vessel, what would happen? It's going to disintegrate or start to deteriorate that vessel wall. If it gets around the cells, it's going to deteriorate the cell wall. And you can see the cell wall in this diagram is starting to become compromised. It's starting to weaken. It's starting to leak, and it will eventually become destroyed because of the acid. Okay, so this is what happens without oxygen. Now, if we can't keep our cells alive, they are the foundation of life. If we can't keep those alive, then your patient is not going to stay alive long term either. Okay, so let's talk about how to recognize this poor perfusion. Okay, so first thing we have to understand is when oxygen starts to become in short supply for the cells, it's going to communicate to the brain, and the brain is going to try and compensate and make this better. Okay. First thing it's going to do is it's going to take the heart rate and ramp it up to try and create more blood pressure and move the red blood cells around in our system faster. Okay. Second thing it's going to do, it's going to take that respiratory rate and ramp it up to try and make sure that we have ample oxygen available for those red blood cells. Okay. Now, normal respiratory rate's 12 to 20. So you're going to see that respiratory rate go up. They're not necessarily working hard to breathe here, guys. It's just a rate issue. And if you're not counting respirations, I guarantee you there'll become a time in your career that you will miss this. And it's one of the big signs. Okay. Your body's also going to constrict the vessels. So it's going to take our pipes and make them smaller. Because if we make the pipes smaller, the pressure goes up. So this is an attempt to raise the blood pressure. And again, move the red blood cells and oxygen around better. Okay. And then the last thing it's going to do is activate the sweat glands. Because with all of this going on, our body is potentially going to create a lot more heat. Remember we said that the cells with oxygen create energy and heat. So if our cells are creating more heat, and there's a bazillion of them, our body's going to overheat. So the sweat glands is that evaporative cooling system that gets employed just to make sure that we don't overheat. Okay? Now, none of that is hard. This is called the sympathetic nervous system. And you may have heard that term and probably thought, yeah, that sounds scary too. I had heard this term a lot. And although I knew it was there and I kind of knew what it did, I still didn't know why. I didn't understand. And, you know, this whole medical thing works a lot better when you understand the why. Okay. So when the sympathetic nervous system kicks in, that tells us the body is compensating for something, most likely lack of oxygen. Okay. So that lack of oxygen could be because I've just run up 9 flights of stairs. Well, for me, 2 will do it. So I'm not lacking oxygen. Like I can get oxygen in my lungs, but I'm not keeping up with what my body is requiring while I'm running up the stairs. So the sympathetic nervous system steps in, ramps everything up, makes the oxygen available to the cells. When I stop running up the stairs, everything goes back to normal because my oxygen demand is not as high as it was before. Make sense? So, sympathetic nervous system. We need to know what this is, so we need to know how to recognize it. So to recognize it, okay, the heart rate. We see the heart rate goes up. It does. The problem is, we've never seen this patient before. What is their normal heart rate? I mean, I have one of my instructors. His normal heart rate's like 40. That's just normal. He's just that healthy. I'm not that way. Okay. So unless you know what the normal is, it's really hard to know if this patient is necessarily tachycardic or not. Now, there's some medications that people take that keep their heart rate low. So if you have a patient that's going into shock and the sympathetic nervous system kicks into gear, that medication is going to block this heart rate. So if that's the thing we're looking at, we might get fooled. So that one, although it's good to know that it will happen, is not always a good indicator. Okay. Second one, remember we talked about that respiratory rate? This is where it's going to be important. Okay. It's not that they're working hard to breathe. It's not always that they have abnormal lung sounds. Nothing. It's just that rate kicks up. So a normal rate is 12 to 20. Okay. When you see a patient breathing 26, 28, they're in trouble. They're in serious trouble. And so that magic number of 30, if you're breathing 30 times a minute, you do not have time to have that gas exchange at the alveoli. So we don't have time to get the oxygen into the bloodstream and the carbon dioxide out. The patient's in essence hyperventilating. So now the sympathetic nervous system that is supposed to help the patient kind of end up working against them. So this is a good predictor. We need to count our respirations. Okay. Skin color. Okay. Now we all know this is a little bit tricky. If you have a patient who, let's say, is African American or Middle Eastern and has a very dark ethnic background and dark pigmentation in their skin, okay, that doesn't mean that anything changes with the process of shock. It just means the pigmentation makes it harder to see on the skin. But you know what? You don't know what color Caucasian people are either. There are some Caucasians. I have a sister-in-law who's almost 100% Irish. Okay, she's pale all the time. She's always pale. She's a healthy pale, but she's pale. Okay, and then you have people that are not. They're robust and dark and look great. So here's a good tip. Okay, when you are looking at a patient and looking at their skin tones, when we're looking for shock, okay, simply take your finger and pull this lower eyelid down and look at that mucous membrane right in there. It should be nice and pink, regardless of where your heritage is from. Even if you have very dark skin, that will be pink if your perfusion is good. If that becomes pale, then your patient is in shock, and we will call them pale when we document on our patient care report. Okay, so that is a huge predictor, probably the best one for recognizing shock. Okay, so don't forget to look. I get my mom finger out when I do these. Okay, and the last one we want to take a look at, this isn't always a predictor, but I want to check it, is a blood pressure. Okay, now sometimes I know if I've got a bounding pulse out here on the wrist, on the radial pulse, and it's bounding, I know I've got a good adequate blood pressure. I don't really need to check it. But if your patient is looking like they're in shock, grab a quick blood pressure, and then I want to watch it. If it is declining, they're in trouble. Okay, if it's staying adequate, then we're not so much in trouble. Okay, so compensated shock. Compensated means it's more work for the body than on a normal day, but the blood pressure is remaining adequate. Okay, so if I look, my patient may be pale. Okay, they may be a little sweaty. Their heart rate and respiratory rate may be up. So I know they're in shock, but their blood pressure is okay. Then they're in compensated shock. Okay, because if I have a good blood pressure, I can move those red blood cells around and I can get oxygen to the cells. So we call this compensated shock. This, guys, is hard to recognize, okay? Because those signs are subtle, okay? There's no neon light that says, I'm dying. But quite honestly, if you have a patient that's in shock, they are indeed in the process of dying. And it's our job to recognize that early, okay? So that compensated shock, that buys us some time. That says if we can find the problem and fix it, we can probably get this thing taken care of, okay? If we can't find the problem and fix it, let's get them to someone who can, okay? They're still sick. They're still dying. They're just not dead yet. Now, when we step over to decompensated, this simply means that no matter how hard the body's trying, the heart rate, the respiratory rate, the vasoconstriction, all of that, no matter what it doesn't have enough energy to keep the blood pressure adequate. Remember those cells that are lacking oxygen? They're not producing energy. They're not making energy. They can't do their job. And so when that starts to happen in systems and in tissues, then the blood pressure is going to drop simply because there's no energy within the body to keep it up. Okay? Now, we're still going to see a rapid heart rate. We're still going to see pale skin. We're still going to see an increased respiratory rate. The body is still trying. It just isn't getting the job done, and that blood pressure is starting to dive down. Okay? So if I see it declining, I'm going to say they're heading into decompensated shock pretty rapidly. If I see that blood pressure below 90, They are absolutely in decompensated shock. And the next step is irreversible shock, or multiple organ dysfunction syndrome, MODS is the new thing they're calling it. Either way, once we step over into there, there's very little chance we're going to get this patient back. It is easy to recognize shock in the decompensated stage, but it's very late to treat it. So our job is to recognize it early. Okay? So this is all about perfusion, not pulse oximetry. Okay? The reason is, if the body is shunting the blood to the core, we've got that vasoconstriction. It's shutting the blood flow down to the skin and keeping it to the core of the body where it can perfuse the brain, the heart, and the kidneys, those things that we have to stay alive. If that's what's happening, and we're trying to measure pulse oximetry clear out here, we don't even have very good blood flow out here. And the blood flow that's here is trapped in those little capillaries that have shut down, and it may indeed have oxygen attached to it. But if I have very little blood flow, I can't always trust my SpO2. Okay? So monitors will fail you. Do not rely on that to tell me that my patient's in shock or not. Look at your patient and treat your patient. If they're pale, okay, if they have an increased respiratory rate, and if their heart rate is up, or even if it's not, these people are in shock. Treat them like that. Remember the shock treatment. Oxygen, lots of it, because the cells are lacking it. Keep them warm, lay them down flat if at all possible, and rapid transport. Okay, these people are actively dying. We got to fix it. Okay? So, not so hard after all, right? I think if you keep this simple and look at A, is my patient in shock? And B, is my blood pressure adequate? You're going to be able to recognize shock and determine, are they compensating well or are they not? And that's really what we want to know. Okay? Now, this doesn't talk anything about the causes of shock. But if you can recognize this, you know that your patient's in shock. Hope this helps. Have a great night.